Just waiting for her beautiful voice to tell me what's up.
Yeah, if you want to go ahead and get started, you can.
Okay.
Not like you needed my permission, but
I wait for it though. I do. Well, thank you all so much for joining us today. This is our, I guess, second learning session and really our first practice coaching call. We're combining them today, so we have a full hour ahead of us. Here's what, again, I should introduce myself. I'm Lori Sharon Windland. I'm the Director of Immunization Programs at Ohio AAP. And I also am the project manager for the HPV QI project. So if we haven't met yet, nice to meet you, and you'll probably get a million emails from me. So I apologize in advance. So we're going to quickly just do introductions with a quick icebreaker. And then we're going to turn it over to Dr. Crick, who's going to talk about best practices for HPV vaccination. We're going to turn it to our pal Zainab, who's going to go over some data and have a quick discussion. And then we're going to do a quick PSA report out and discussion, and then real quickly go into reminders and next steps. So first, we are going to do a quick icebreaker. And so we figured it was just a nice way to kind of get us started, but there's quite a few of us on the call. So if we can just have one representative from each practice, introduce themselves, do the icebreaker, and then just let us know who else is on from your team, that would be great. So our icebreaker question is, what is the worst haircut you ever had? So hopefully you have some fun stories to share. And I don't know if Dr. Crick and Dr. Karras, if you want to introduce yourselves really quick.
Happily. My name is Dave Karras. I'm a general pediatrician at Akron Children's, and I'm working as the vaccine subject matter expert. I don't know if I'm visible on the call, but I am clearly bald at this point. But I do have two bad haircut comments. One is it must have been the mid 90s, 95, 96, and a girlfriend convinced me to get a perm. It's probably a little late for that. But then it must have been my freshman year of college. My dad came to town and was going to give me a haircut. And somehow he had two pairs of scissors in his hand. One were these regular scissors and one were like these thinning scissors. And he used the wrong pair and used the regular scissors and cut all the way down to my scalp. And it prompted me, it was so bad I had to shave my head. And so that was,
and it
that
never
was the first. No, and I've been shaving it ever since.
Well, thanks for being on. And Dr. Crick? That was an awesome start for the icebreaker. And since I'm on the same team as Dave, I will not come up with a bad hair day for myself. But I'm Kate Craig. I am a general pediatrician and also the associate medical director at Partners for Kids with Nationwide Children's Hospital, and the co-chair of the Planning, Implementation, and Performance Committee of the Ohio chapter of the American Academy of Pediatrics. And thank you all for joining us.
Awesome. And before we jump into the practices, Zainab, if you want to say hello real quick, I know you're on today as well.
Yes, I probably won't share a bad hair day because we're still part of the same AAP. But yes, I'm Zainab Al-Abdali, and I am looking at most of the data that you guys are sending us. So thank you for that. As we move forward with the slides, we will be sharing some of the data that we already have, and then some questions or concerns that we would like to have discussed before we move forward. And then any questions that you guys have regarding your data or anything else of that sort, we would be glad to answer those for you as well.
All right, I gotta move. I have too many things on my screen. Okay, so for who's on there first? I can't move my people. There it is. Okay, so we'll start with OSU. I don't know if each location is on, but if you guys want to jump in and just say hello and maybe tell us your worst haircut story.
Can you come to us later since I'm driving?
Oh, yes, no problem. Okay, so the pediatric and adolescent gynecology group.
I can talk for us. I'm Natalie Alexander. I'm the clin lead of the nurse of the department here, and we're with Dr. McCracken. She's in the OR right now, unfortunately. And then Megan Castinger is on. She's one of our admins. I don't really have too much of a bad haircut story other than just the word bangs. My mom thought bangs were important, so thank God those grew out.
Yes, I think we all of us ladies, and maybe some of the guys have some bang stories. So, well, thanks for being on. And the Center for Colorectal and Pelvic Reconstruction at NCH. I don't know if we have anybody on. Okay, and how about Dr. I don't know if Dr. Lucine is on from Hilliard Pediatrics.
Yes, I'm here.
Awesome.
Hey, how are you? Yeah, I'm here. I'm Trisha Lucine from Hilliard Pediatrics. I also had lots of bangs, so I'm just going to go with the bangs.
Yeah, we're sad for those. Okay, and I think Meg, I don't know if you're going to speak for school-based health services.
Happy to. I'm Meg Kane. I'm a nurse practitioner with the school health program at Nationwide Children's Hospital, and I have so many bad haircut stories that it's kind of hard to narrow it down. But I will today I will focus on the time that I let my friend cut my hair while we were watching a Murder, She Wrote marathon. And turns out you cannot multitask when you're cutting each other's hair. And like, it was so bad that after that we had to take a vow to not commit hair violence on each other anymore, because I only knew something was wrong because she started crying while we were watching Murder, She Wrote. And actually I'll always do anything for a story. So I thought it was like, actually, it was fine. I just got it all cut off the next day. And actually, neither of us stuck to our vow. We did not learn from that experience. Do you want me to introduce everyone or
Sure.
Should they introduce themselves? Okay. I'm on with Dana Shoemaker and Katie Dowdy and April Mulvane from our group.
Awesome. Well, welcome. Thanks for being on. And then the team from Blue Ridge Pediatrics.
Hey guys, Scott St. Clair from Blue Ridge Peds here down in Boone, North Carolina. I've got Sarah Townsend, our vaccine coordinator, and then Callie London, she's our office manager here. And I will do the bad hair story. Is I went to Duke, and the first week at Duke, I went to the Duke barber and didn't realize, but the Duke barber cut all the ROTC people's haircuts, and he had one haircut, the ROTC haircut. So I did that one time and decided that was not for me.
Thank you for, who else do you have with you? Did you already say that?
Yeah.
Okay, sorry. I'm taking notes. Augusta Pediatrics, I think Dr. Drake is on.
Hey, I'm Jennifer Drake. Kathy Williamson and Ashley Taylor are here. My haircut is actually also, like Dr. Karras, a perm in 8th grade, and it was just bad. So if you can picture little orphan Annie, that was pretty much what it looked like. So it was pretty traumatic for both my mom and I. Multiple arguments every morning about what to do with it. So.
Well, thank you for being on. And I will turn it over to Dr. Crick to get us started.
Thanks, guys. I'm always super thrilled to hear about bad haircuts. It's funny to go back and reminisce about the good old days. And kudos to Meg for just cutting it off the next day, because I would have lost like 3 years of my life just stressing about that. So today I'm going to talk about best practices for HPV vaccination. Some of this is actually going to be review. Some of this we're going to touch again at the end of this call when we talk about what you all are doing for PDSAs. I was really excited to see that a lot of what I have in this presentation you guys are already working on. So very cool, very good work. So you can go to the next slide. So I broke this into several categories just to kind of help organize, which category you want to work on. Normalizing the vaccine. I think we're all very well aware that HPV from the get-go has stood out as that other vaccine, a vaccine that has a lot of hesitancy around it that other vaccines have not had. It is often approached as sort of separate and other, and anything we do to normalize it as this is, very similar to all the other vaccines that the majority of parents and patients consent to without really thinking through. And those things are listing it in ways that don't set it apart. So the announcement strategy, today your child is due for 3 vaccines. And the sandwich strategy, sandwiching HPV into 2 very well accepted vaccines. So Tdap, HPV, and meningococcal vaccine. So to make it part of the norm and not set it apart as other. I think a lot of us have a tendency, and not just us, but all the staff that works in our office, when we talk about it, the required vaccines are this, and then there's this other one. And if you have questions, you can talk about it with the doctor, and really setting it apart is different, and just changing the language to normalize it as this is just sort of standard routine process that is very much in line with all the other vaccines that we do, actually goes a very long way towards increasing acceptance. Next slide. We don't talk enough, I think, about really why we have this vaccine. We talk a lot about things like sex and transmission and not enough about cancer. Along with this, I didn't put it in here, but I think it goes sort of hand in hand, is like any other vaccine, you lead with the benefit and follow with the safety. That would have been good on the slide, and follow with the safety. But to say, to really restructure the conversation of HPV vaccine around why do we have this, just straightforward, HPV vaccination prevents cancer, or HPV is the vaccination is the cancer prevention vaccine. And along with that, the benefit is this prevents cancer, and this is an incredibly safe vaccine. It is just as safe as the other vaccines that we offer in this age group. The safety profile is excellent. Obviously, you don't need to harp on that, but to just say, if the conversation leads to why HPV or anything about HPV prevents cancers, and the safety profile is excellent. This is a very, very safe and very, very effective vaccine. Next slide. This is the big one. Hesitancy, and there are some strategies that do not have to take an inordinate amount of time that can really help frame a more productive conversation around vaccine hesitancy. That starts with you and your staff, all the providers and all the staff. There are lots of different sort of attitudes and beliefs around HPV vaccine. And if everyone in the office that's interacting with patients is not on the same page about this vaccine, it can completely derail your efforts. So it is important to understand what are those beliefs, and then really sort of correct the inaccuracies in the conversation. So even if your staff maintains they would never get this for their own child, correcting the way they have conversations around patients to highlight the benefits, highlight the safety, and make sure that they are following your recommendation for a strong recommendation. How the rooming staff, who has sort of the first contact with the patient in regards to discussing HPV vaccination, words their language around vaccination, has a huge impact on whether or not that patient will accept this vaccine. Even if they get to the point of having a conversation with you and you do all the right things, if that conversation has been initiated with other language or set apart language or not a strong recommendation, or this is not required or anything, you're already behind the 8 ball and you're much less likely to be successful in your conversation. So it is really critical that you know what everyone who's interacting with patients feels and overcome that for a strong unified statement that's based in science. Next slide. So this is where I really think the money is at. There is, there's a lot of patients who will just accept what you recommend. And there is a segment of patients who will never accept any vaccine or never accept the HPV vaccine, no matter what you do. And then there's a big chunk of vaccine hesitant patients and families who really value your opinion and will really engage in good conversation around whatever is triggering their hesitancy. And those patients can absolutely be moved. And even if you don't move them on the first conversation, they can be moved over a period of time. The beautiful thing about pediatrics is the continuity of care we have. And so we really do have a great opportunity to identify what is the reason they're hesitant to really address it in straightforward language and to continue that conversation and try to move them into readiness over a period of time. I can't tell you how many times that happened, that patients had just heard something and they were like, no, we don't want it. And then we moved slowly over sometimes a period of a couple of years into, okay, we're ready now to go ahead and get it. I don't think I used it in here, this term motivational interviewing. Whenever I hear that term, I sort of get really anxious because it was taught to me in a very scripted, stressful 30-minute conversation way. But motivational interviewing is really just finding out where they're at and then moving them from there. So this is sort of my 4-bullet point on motivational interviewing in HPV vaccine hesitancy and really any vaccine hesitancy and honestly, really kind of in how you have conversations with patients about anything that you need a little movement on is make sure that everybody is on the same page from your end of things, which we've already talked about. You can actually even use scripted language to make a very strong universal recommendation. So that would be using the announcement approach and the sandwich approach and no other language. And you can even just script that for your staff so that that's the language they use. Today, your child is due for these 3 vaccinations, sandwiching HPV in the middle. And that's the end of the sort of scripted language. And if they say, well, we don't want HPV, okay, I'll have the doctor, discuss that with you or the nurse practitioner or, pass that part of the conversation on to the provider, but not engage in, well, this is not required or that is just, these are the recommended, this is what you're due for, kind of matter of fact. That will go a long way. And then, again, we also talked about already emphasizing the benefit and the safety. So I always lead with that. If there are questions, some people are just gonna be like, okay, fine, but we don't want that one. Asking permission to have further conversation. Most of the time, families would say, yeah, let's talk about it. And occasionally they'd say, no, I'm not getting it and I don't want to talk about it, and respect that. That's okay, that's their choice. Move on. You're not probably gonna win over that patient. So most of the time they'll say, yeah. And then I'll say, so the HPV vaccination prevents cancer. Here's the types of cancers that it prevents. It's incredibly effective in preventing these cancers. And it's exceptionally safe. This is one of the safest vaccines we have. can you tell me about what your concerns are with this vaccine? And then whatever they are, address that very specific concern, and then just sort of figure out where they're at. And they may not be at, okay, I'm ready to get. Sometimes they are like, wow, thanks for having this conversation with me. It does sound really important. Let's go ahead and do it. Sometimes they're like, okay, that makes sense. Not really ready to do it today. And sometimes they're like, thanks, but no thanks. And I'll always close that conversation with, hey, thanks for sharing your concerns with me. Is it all right if I bring this up at the next visit? Now, because that's doing what they're asking me to do. But that is pretty rare. So most of the time I'll ask, can we have this, my
You're breaking up a little bit, Dr. Crick.
Okay, I'm going to turn my video off and see if that helps.
Okay. Sorry to
Can you
interrupt.
hear me now, or am I still breaking up?
You're frozen. Did you turn
Am
your?
I still breaking up, or I turned my video off?
Keep going. We'll see. Did we lose you completely, Dr. Crick?
Yeah, I think we did.
Okay. Let's see.
It looks like she's on here.
Yeah, looks like.
Can you guys hear me now?
You're still breaking up a little bit, but we can hear you.
I hesitate to just keep talking if you guys can't actually hear what I'm saying. I don't have a fix for this unstable internet. I'm guessing you guys cannot hear me.
No, we can hear you. You sound a little better.
Yeah, she does sound a little better.
All right, so anyway, I think I was done with this slide, and we may actually be coming to improve access. This is just using processes to make sure that people don't slip through the cracks. So using non-well visits to give vaccine, to offer HPV vaccine or any vaccine, having standing orders so people can come in for vaccine only visits when they're all caught up on their well care. Standardized scheduling for follow-up doses helps get kids back. If you actually set a schedule for, here's your scheduled appointment to come back, even if it's a nurse only visit, they're more likely to come back and get it done than if you just tell them they need to come back in 6 months. And initiating HPV vaccination at 9 years of age certainly increases the access to vaccine. Sometimes it eliminates a lot of the conversation around, sex and sexual debut and all the sex talk, because at age 9, it's more just about vaccination and cancer prevention. Next slide. And then technology, I think this is my last slide. Electronic health records are really good at identifying patients who are not due for, or who are overdue for certain services. So using chart alerts so that when you're in the chart, you get a reminder that this patient is due or overdue. Using recalls to recall patients. It's essentially outreach to a group of patients who are due for certain services to get them back in for those services. Technology can be an asset, a big help in identifying all those patients who need to come back in. And then using the state registry, Ohio, or I'm assuming for those of you who are not in Ohio, you probably have a state registry as well. It's not necessarily a complete list, but it can help fill in some of the gaps for people who are uploading, practices or providers that are uploading vaccines that are given, it can help fill in some of the gaps of what a kid has or has not had.
And that link, we will send these slides, but that link will give you kind of a detailed report or detailed instructions on how to pull that report and impact. So just thought we'd include that. Okay.
That's all I have for now.
Well, thank you, Dr. Crick, and we'll turn it over to Zainab.
Yes, so the next couple of slides, we're going to be discussing metric 1 and metric 2. In the slides, you'll be able to see data from the combined practices. So all of your guys' data in one chart. And then we'll also look at individual practices, at least the ones that we have some data for. So in this first slide, you can see for metric 1, we have a baseline point, and then we have the April data, which is the first quality improvement month. And as you can see from the graph, we have had a slight decrease in the number of vaccine completion rates from baseline compared with April. It is not a significant decrease after a t-test was performed. This is not a significant decrease. However, we have seen values like this in previous projects, or at least I have, where the first month of the quality improvement months has had a slight decrease. But we're hoping to see that number increase as we go through the months and as we collect data for that. Next slide. And so here we have data from the OSU clinics, the Grandview, Hilliard, and Lewis Center. And as you can see here, again, we are seeing slight decreases in all of them or throughout the board for metric 1. I would like to note that for metric 1, we are looking at, yes, we are looking at the past 3 years, but every month that we are pulling that data, there are individuals that are dropping out of that denominator. So if they're turning 14 or if they're 12 turning 13, those are either dropped out or included within the denominator. So I would just like for everyone to have a refresher on that, just in case, you know, there's some confusion on how data for metric 1 is collected. And again, as we move through the slides, you'll notice that we have usually one baseline point. And although Dr. Kirk mentioned that she, you know, that one baseline point is enough, which it could be, if we could have at least 2 baseline points, that would be great, just so that we have more of a trend to compare as we move through the QI months in May and June. So I'm ready for the next slide. And here's also, again, metric 1 for the rest of the clinics that we have, or the rest of the practices that we have baseline and April data for. NCH are the only, so for the baseline data, they have their denominator as a very large number compared to their April. So whoever's on this call that, you know, sent in this data, I'd really like to ask if maybe you could look in to see if that data was sent to us correctly for just that baseline month that you sent us, rather than all the patients for the past 3 years. And then Blue Ridge Pediatrics has had a slight increase, as well as Hilliard Pediatrics. But we hope to see a more dramatic or a more noticeable or statistically significant increase as we move throughout the months. I'm ready for the next slide. And then here, metric 2, which I was very pleased with the results that we were seeing almost throughout the board. We were seeing very large increases in vaccine administration rates. So in all the practices combined, so all the data that we have baseline and April data for are combined into this one table. And overall, we saw a 46% increase in vaccine administration rates from baseline compared with April. And when a t-test was performed, there was a statistically significant difference between baseline and April, which is a very good sign. And hopefully, like I said, as we progress through the months, we will see an even greater increase, or at least somewhere near that 64% overall for all the practices. I'm ready for the next slide. Here for the OSU data, a lot of the baseline or the baseline for Grandview and Lewis Center, actually that's supposed to say metric too, that's my error on the titles for those graphs. But anyway, so for the baseline for Grandview and Lewis Center is an estimated baseline from me. The program that OSU or these clinics or these facilities use to pull that data is Splicer Dicer, which apparently they're having trouble with pulling some accurate numbers until they gain more access to the program. So those are the 50% for Grandview and Lewis Center are estimated by me. And I'm assuming that it'll be close to that once you get that data. But then the April values for all the practices are accurate based on the data that was sent to us. And in all of them, like I said, you can see a large percent increase from baseline compared with April, which is again a very good sign. We can move to the next slide. This data is all accurate. I did not have to estimate any of this data that's on here. So for Blue Ridge, Hilliard, and Augusta Pediatrics, we did see a great increase. Especially for Hilliard Pediatrics, we saw a 200% increase in their vaccine administration rates from baseline compared with April. For the last one, the NCHKD, what I did was I combined baseline 2 and baseline 1. I combined those and I found the average and I compared that with April. And there was a decrease of 63%. But again, that's usually not a big deal as long as when we move throughout the project, that number does increase. So that's the data that I had to share for today. I'm not sure if anyone has any questions or if they have questions about the graph or questions about data collection or anything like that. This would be a really good time for you to ask that question. Hopefully I'll be able to answer, and if not, then I will definitely get back to you and Lori, and hopefully those questions will be answered.
Yes, we can open it up if anybody has any specific questions for Zainab. And if you need to look at this for a minute and process it and get back to us with any questions, feel free to do that as well, just like she said.
Definitely. And I do want to mention that for a few practices, we are missing some baseline data. So that would be great if you could send that to us whenever you can. Let me see if I can look in here to see which one.
I know with the school-based health centers, I know had an issue pulling their baseline.
Yes, I think they're the only ones that we still want baseline for.
I have a question.
Mm-hmm.
Several of us had discussed just using 11 and up versus 9 and up age-wise. I think our baseline may be including the 9-year-olds, and our second one may be including just 11 and up. So I think we're looking right now to see what our numbers were, but are all of them, are these apples to apples, or are we looking at different ages?
I think we're looking at different ages. I think the majority of people are doing 11 up, but I think I'd have to go back and look. And we could make a note on the charts too.
Okay.
All right, we're looking at our numbers too.
Yeah, look at your number. And if you need to resubmit, we can.
Yeah,
Okay.
definitely. This is just very preliminary. So please, if these graphs are stressing you out, please don't let that happen. Like I said, they're very preliminary. We're only looking at 1 month right now. And the project spans like 4 or 5 months, right, Lori?
Mm-hmm.
So there's still a very large opportunity for you to increase those numbers. So yeah, don't be stressed out by these numbers. These are just to show what we have right now. But there are no means trying to tell you like, oh, you need to do better, or these are just information for you guys to decide how you guys want to move forward based on the data that we already have right now.
I think our increase wasn't as much as it looks like, because I think the first one is including a lot of 9-year-olds and the second one is not. So, I mean, we have, I think, gone up a little, but I don't think it's as dramatic as it looks. So.
And I would just reiterate, that's a great call out, Jennifer, that is probably not apples to apples. And, you know, in the first month, nobody had really done any work on this. There's no reason to think that it would have gone up. I think, you know, sometimes, particularly with metric 2, you know, just knowing that you're going to be focusing on HPV does provide some improvement because it's on the top of your mind. But I think the real takeaway from this is, you know, what is your baseline, and not necessarily that strict number at the baseline category, but probably somewhere between the baseline and the April number is more of a true baseline. And you're going to use that to determine what your goal for this project is going to be, keeping in mind that it is time limited. It's only about 6 months. I'm pretty confident that everybody will see improvement over that period of time. You know, how much do you want to push yourself for the goal? There's no, you don't like lose your MOC credit if you don't meet your goal, but you also want your goal to be somewhat realistic and not unattainable. So that is something we're going to ask all of you to be thinking about in the next couple of weeks. You know, where are you starting from, and what would be success in this project to sort of narrow down what that goal is going to be. Like Lori said, we'll provide these slides to you, and then you can take a look at these and really figure that out based on what your data is showing. Metric 1 is going to be a slower mover. It's completion rate. So metric 2 is just, did you increase the number of vaccines you gave? Metric 1 is, you know, only 13-year-olds, and are they completed by the age of 13? It's just a harder metric to move. I do think you guys can probably move it. It's not going to move as quickly or as much as just strict HPV vaccination rates. But then at the end of the day, if you're increasing your HPV vaccination rates, you have been successful. So I feel very, very happy with even knowing that it's not, you know, perfect data, that it's sort of a good gestalt of where you're starting, so that you can make some informed decisions about, you know, what you'd like to strive for to finish. And the fact that we're already seeing some improvement with really, you know, very little work having been done. All of you guys have done great work on the PDSAs, but at the point that this data was collected, you probably had not done very much. So it's pretty impressive to see movement at all.
Awesome. And if you guys have any other questions as you sort of look this over, again, please don't hesitate to reach out, and and if you think, oh, maybe we submitted something incorrectly, or, oh gosh, we can get the baseline now, or the slicer dicer, whatever that's called, it's been, you know, fixed. So just keep us kind of in the loop, and we will kind of move from there. But I'll turn it back over to you. Thank you so much, Zainab. And I'll turn it back to you, Dr. Crick. We're going to do a quick PDSA report out and discussion.
So it was actually really cool, all your PDSAs, because you guys are already doing a ton of cool stuff. And there was a little bit of overlap, but like across the project, you guys are like hitting so many of the things that we talked about in the introductory visits with each practice. My internet connection is unstable again. Can you guys hear me? Why is it only stable when I'm talking? That's weird. Anyway, this is just a list of what people are working on. The number afterwards represents how many practices are working on that measure for the first PDSA cycle. Those cycles did not include results. And I understand why that is because of the timing. When you have to turn it in, you don't necessarily have results. But if I could ask you guys all to go back, if you have not completed the results section, and please do complete it and then submit it. Because what tends to happen in similar projects is they never get resubmitted. And so we end up with a whole bunch of PDSAs that have the results sections on them. And so you don't necessarily learn from what you learned during your PDSA cycle. But some of them did have results, so I've put those results in if they were there. So one group was working on changing language to cancer prevention, and if I'm understanding it correctly, they, instead of using the name HPV, and I may be wrong, correct me if I'm wrong, but that they said, and you're due for the cancer prevention vaccine. Patients are very confused about, well, what about HPV? We haven't even talked about.
Uh-oh, did we lose her? I didn't mean to call her a loser. Did she jump off? Oh, Nebraska internet. It's never
Can you
stable.
guys
We're starting to hear you, but you're still breaking up quite a bit.
How about now? Can you hear me now?
It's getting a little better.
Clearly not. Feel like an old Verizon. Is it Verizon or Sprint? Can you hear me now?
Yeah, you're sounding better.
Okay, so I just dropped suddenly, but anyway, just changing the cancer prevention vaccine to HPV as the cancer prevention vaccine. I think that is very clear, straightforward, fantastic language. Hopefully that would fix the problem with confusion, that we are talking about HPV and it prevents cancer. The specialty clinics, that was, well, I don't need to call out specific clinics, but are calling calling the PCP to find out exactly which patients have had HPV and if they're due, offering it there, and the patients absolutely loved it. And so they're ready to just adopt this and expand it. And then the other one, the sandwich language, which you're gonna hear a little bit more about in a few minutes. That change in language to sandwiching HPV in the middle was very easy for providers. I put here data pending, but I actually then got the data and neglected to update it. You'll hear more about that in a minute, but that was found to be very successful. There's some little minor changes that they want to make, but this they adopted and they're going to expand it. And then one group wrote what they're going to do in their next PDSA, which is to use the REC card that we provided to patients to kind of facilitate the conversation. So at this point, you know, like I said, this is a great, fantastic set of kind of across the board PDSAs that you all are doing and finding ways to help make it be more successful and already finding some success with it. So again, if you can actually complete the results sections and resubmit that, that would be really helpful for moving forward. And then the second step is to decide, are you going to do more on this particular topic, or are you ready to start a new topic? So you can go to the next slide. All I did with the next slide is just take from that best practices list and some other notes I had taken, options for additional things that could be considered. Obviously, the previous slide, you know, you only did one of those, or some practices actually did 2 or 3 PDSAs. You know, you can switch topics to in there if you're ready to switch. Here's some other ideas that just came directly from the best practice visits. One thing I wanted to highlight is about, so I think it's actually metric 3, which is documenting that the discussion happened and that the caregiver declined. Most practices do not have a process for doing that. And it may be worthwhile developing a process to do that, not just so you can better understand and verify that those conversations are actually happening, but in the future, at some point, that is going to be important, that you can show that you did have the conversation and that the caregiver declined, as opposed to you didn't bother to have the conversation. So, you know, there's no sort of incentive or penalty if you don't do that now, but I would suspect that probably within the next few years, there will be. And that can be done with a code that says caregiver decline, there's a specific ICD-10 code about when a caregiver declines a vaccine. And so developing a process around, that was discussed, but the caregiver declined is, not something that you necessarily have to focus on, but could provide some benefit to you in the future. And the next slide, we actually asked Dr. Jennifer Drake to report out on her PDSA cycle. She was able to provide results. And so I thought it would be a nice opportunity to see kind of from start to finish what their thinking was and how they worked through the process. I think this is really a kind of poster child gold standard, gold star on starting small and using what you learn to sort of move forward. Thank you, Jennifer.
Thanks for putting me on the spot. No. So we actually had a very mini one before this that was just one doctor doing it for her 2 days a week that she works for 1 week, and just to make sure that there weren't any unforeseen problems or anything like that, and that was fine. We didn't collect actual numbers data on that. It was just more the ease and the reaction that she and her nurse had, and that was fine. So with this one, we decided to just use that. And I'm realizing now we sort of did the two things that you said, saying they're due for and sandwich language it. So I don't know if we needed to be more explicit about that, but because in the past we had a lot been saying these are the two and this is the one. So and then we put it in the middle. We did feel like it was relatively easy to do. Our doctors, a couple of us had a couple conversations about it's just a change in what we were saying. And so we had to kind of think about a little bit more before we started speaking about it. One person said he had to really think about a way that he didn't feel like he was misleading anybody, because he didn't want to say it was required when it wasn't. And so he kind of stumbled over that at a time, but then just recommended, someone suggested just these are the vaccines, which I like your term, they're due for these vaccines. And then apparently a couple of patients still did ask if it was required. And then of course that conversation, we're not going to, we're going to be honest and talk about that. So those were, I guess, some issues that came up. We did collect the data. Kathy pulled that for us and we just used that. We just did it for a week, all 9 of us. I think one person didn't actually have an 11-year-old that week, but everybody else at least had 1 or 2. And then Kathy pulled that data and compared it to a week back before we started doing all this. And it went up 5%. So I guess our question now is, was that just chance or is that, a trend? And so we're going to continue doing that for a little bit longer for our next cycle, and see if it's real. So what else? Any other comments we need to make?
I just think that was a really great example of how, and especially that you clarified that you actually started even smaller than this, but that's exactly the way to do it, is start so small that it's totally not a big deal. And then like, oh, this is totally not going to work, or I think this will work. And then you expand it a little, but in a very manageable format. I love that you picked, you're right, you did do kind of the two things at once, and that's exactly the right way to do it. And it makes a difference. So yeah, I don't know if that was statistically significant or not, and we'll find out as time goes on, but just to make that one change, you normalize, you used all the normalization techniques. It has been shown that that is a very effective strategy for improving consent to HPV vaccination. So you did it in a way that was really manageable. You got some really great information, and you're really, well into a very successful intervention.
That's
So
awesome.
excellent work. Does anybody have any questions around PDSAs? They can be specific or general, but that would help you feel a little more comfortable in this process of designing and carrying out PDSAs. I'll take that as a no, but if you're just too shy to speak up, just send us an email. Let us know what your questions are. So you can move forward, Lori. Thank you, Jennifer.
All right. Well, Thea, thank you both. That's a great discussion. And again, if you, just as Dr. Crick said, if you're working on your second one, your second PDSA, and you're like, oh, I have a question, don't ever hesitate to reach out. So we're just going to ask a quick poll. I always screw up these polls, so bear with me. Do you see a question on there? Did question pop up?
No.
Okay. So I'm going to hit launch and see.
Now I see it.
Okay, so go ahead and answer this question. Again, it's anonymous, but what does your practice specifically need more help with? So fill us in and we can kind of tailor some more education. We can get you some additional resources, but we're really curious at this point, do you need more help with PDSAs, addressing vaccine hesitancy, goal setting and project timelines, data collection? And I think I gave it the option to do multiple. So if you're like, I need help with everything, no shame, just let us know. More collaboration with other practices, or if there is something else that we're sort of missing in there, please let us know. I'll give it just another couple seconds and we will look at the results. I think that's probably everybody. I'm going to go ahead and end it. And I'm going to share the results. Can you guys still see that okay?
Yep, I can see it.
Awesome. So it looks like we're still need a little more help with data collection, data analysis. So again, we're just getting started on that. So we will, any help as you start pulling your next round or as you kind of look over these slides, do not hesitate to reach out. We'll definitely dive into that a little bit more. Anyone else with the more PDSA help? I see that one person still needs that. Again, we are here. We do have, I know we had one of the work recordings was about PDSA. So make sure you take a peek at that. And then we also sent a link a few weeks ago that has a YouTube tutorial. So that is also helpful. Vaccine hesitancy, we do have, in addition to Dr. Karas's wonderful presentation, as part of here in Ohio, we have our Moby and Ties, our immunization trainings that are offered to everybody. And part of those trainings, so we have a childhood and an adolescent, but part of the childhood one includes a separate module on vaccine hesitancy. So if you're interested in getting something like that scheduled for your entire office, we provide free CME and different resources. And then the ties that adolescent is more specific to, obviously HPV and meningococcal and all of those. So if you would like a little more help with that, please let me know. We can get those scheduled. And then goal setting and project timelines. If there's something specific, and Dr. Crick, I'll let you jump into. Again, I feel like we're just sort of getting on track here with everything as we begin. So as we move along, if there's something specific anybody needs, we're again here to help.
So I hesitate to put anybody on the spot, but specifically the goal setting and project timelines, we are going to ask that you all submit that in the next 2 to 3 weeks. And so if you're willing, can you come off mute and actually ask, can we have a short little conversation about what would you need or what is your question around goal setting?
And I'm going to stop sharing this, but you'll see too, the slide I have up. So we're going to just to kind of put it all on kind of paper for us. So we're thinking about the goal setting. They need to be reasonable, optimistic, utilizing that baseline data. And if you guys can send a draft to me just to share with our internal group by June 10th, I added it to the timeline after this. So if whoever needed more help with the goal setting and all of that, if you want to chat about it, or if you want to email us, and we can always schedule another quick call as we look at it, whatever is easiest for you guys.
And
everyone.
assume the silence means you'll hopefully connect with us offline, so we can give you a little more support in that.
Perfect. And I know we just have a couple minutes left. I don't want to go over. So, these are the, obviously the goals that we're going to be looking at. And so increase individual provider confidence. I think I missed a word there, or a couple words there. But we have that information too, so we can help you with that goal setting piece. But then just real quick to mark your calendars, I did add in the draft goals on June 10th, but we're looking at our next data poll and PDSA cycle, both due on June 7th. And then we have our final kind of learning session, and then we'll combine it with a practice coaching call on June 17th. And then July, another PDSA cycle, data poll, practice coaching. August, the same thing. We'll be done with the PDSAs there, then to turn in, but you obviously are more than welcome to continue PDSAs within your practice. Share them with us as you'd like. And then of course, September, December. So those are ways off, so we won't dive in too far. But that's all we had for today. So just wanted to open up for any final thoughts or questions. Hopefully this helped a little bit thinking about your PDSAs and seeing kind of a snippet of the data. Again, it's very preliminary, but at least we wanted to show what we have so far. And if we need to make any changes or re-pull anything, let us know and we can get that updated for you guys. And again, for anyone who missed, this is recorded and we will upload this on our website along with the slides. So you'll have everything at your fingertips. All right.
Well, thank you everyone for joining. This has been a really great session. I'm really enjoying working on this project with you. I'm really excited about all the PDSAs that you turned in, all the good work you're doing, even starting to see some improvements in HPV administration rates. I'm really confident that you all are going to really have quite a bit of success. So thank you for your great work and thanks for joining us today.
Thank you guys. Have a great weekend. Appreciate you.
Thank you so much.